hyperlaxity syndrome. And it just looked very much like idiopathic scoliosis, but then it was associated with the Marfan syndrome. Now, skeletal maturity is one of the things that sometimes can cause, if someone is very young and they have not gone through the peak height velocity, the curve could increase just as a function of growth. And just determining at what level of skeletal maturity the patient is very important, because it's one of the important independent predictors of a curve progress. And the one that is most commonly used is the Risa sign, where you are just looking at the iliac apophysis, which starts from the lateral going all the way to the medial. And 5 is when it has fused completely. And just labeling children as Risa 0 up to Risa 5. Then others, of course, the chronologic age is one of the things. Menarche, especially for, of course, that's for girls. If they have already gone through menarche for 2 years, I mean, menarche was 2 years ago, then they have reached the skeletal maturity, and the curve is not likely to progress very much. Closure of the triradiate cartilage. Whitehouse classification is thought to be one of the most accurate. And then Sardus and group try to simplify that for clinical practice. So Whitehouse classification is a very significant one. Now, it almost, just looking at studies that have been done, the peak height velocity, or the period when the child is growing the fastest, is usually before Risa 1. It's Risa 0, and the triradiate cartilage is also open, and also is a premenarche. So it's just good to know that that once you start seeing Risa signs, already you have gone through the peak height velocity for that child. X-rays are very important in evaluation of adolescent idiopathic scoliosis. Usually you are looking at taking an X-ray that hopefully will expose C7, and also at the level of the hips, so that you can see the whole spine. Also, it would be good to include the whole rib cage in that X-ray, because sometimes you can miss some rib abnormalities if you don't do that. So that is a recommended X-ray. It needs to be a weight bearing, or at least it needs to be a standing AP or a PA X-ray. Then after that, you can also do side bedding X-rays, which are usually supine, just to be able to check for the flexibility of the curves that you find that are presenting in the scoliosis. Some people sometimes just put some bolsters and try to get as much correction as possible when they are doing the side bedding supine X-rays. Now, when you're measuring the cob, there are quite a number of vertebrae that usually look at. One of them, of course, is where the apex is. That's the apical vertebra. The head vertebra is the vertebra that is considered to be at the end of the curves, and it's the most inclined vertebra. And also you can look at the differences between the disc spaces on the concave side and on the convex side. And at least on the concave side, it should just be widening so that you just know that that is the head vertebra, and you're going on to the lower curve that might be either structural or postural. The neutral vertebra is the one where the pedicles are very symmetrical on the vertebral body. The stable vertebra is the one that is bisected by the central sacral vertical line. Yeah. And then the cob ergo is just measured from head vertebra to head vertebra, and an ergo can be derived from that. Lenke classification is currently the one that is most commonly being used. It helps a lot to determine what curves you need to include in the surgery that one is going to do, and which ones are structural and which ones are minor curves, but they are not structural. But of course, there are other uses because it just helps in terms of communication between and among surgeons because it's very easy to classify the curves. Now, there are about 4 steps when one was to use the Lenker classification. I will just concentrate on the first 3, maybe even the first 2, and then the others, one could consider them later. The first one is, of course, identifying the regional curves. You can have a thoracic curve, usually where the apex of the curve is between T2 to the disc between T11 and T12. But occasionally you have 2 thoracic curves, one of which is more proximal and the other one is a little bit distal. The distal one, we call it the mean thoracic, and the proximal one, we just call it the proximal thoracic. Then the thoracolumbar usually has an apex between T11 and L1, including the disc. And the lumbar curve has between L1 and L2 disc through L4. So it's very important to identify first what regional curves do you have. The second thing is to identify what is the major curve, and that is the largest curve on a standing AP or PA X-ray. When you do that and you measure all the angles in the regional curves, then the one that is the most significant is the one that you would call the major curve. Now, sometimes you might have a major curve that looks like it's the proximal thoracic. It's bigger than the one that is the main thoracic curve. Then usually one is advised to default to the main thoracic curve. And if you have 2 curves that are competing between the thoracolumbar and lumbar curve and the main thoracic curve, then you default to the main thoracic curve. Then the third thing is to know which of these minor curves, after you have identified the main curve, then all the others, you're going to consider them to be the minor curves. And then you need to know whether the minor curves, any one of them is structural, whether the proximal thoracic one is structural, the main thoracic, if it is a minor curve, whether it's structural, or the thoracolumbar or lumbar curve is structural or not. And that's where the side bending supine fumes come into play. Because at that point, if you have bent it, if it can bend out, but then it doesn't bend out to less than 25 degrees, then that is a stiff curve and it is thought to be a structural curve. Whether it is proximal thoracic, main thoracic, or the thoracolumbar lumbar curve. The other aspect, especially for the ones that are like the proximal thoracic, sometimes it can bend maybe to 20 degrees. But then there is some sort of a kyphosis that is more than or equal to 20 degrees at that level. Then even if it is smaller in terms of degrees, but then there is a kyphosis there, then that one is thought to be also a structural curve. The same thing for all the others. For the main thoracic, you still look at the thoracolumbar junction and see whether there is a kyphosis there. And also for the thoracolumbar lumbar curve, if there is a increased kyphosis at the thoracolumbar region, then you might also declare them to be structural curves, even though the amount of degrees on side bending fumes is less than 25 degrees. And then after that, you can actually classify them between 1 and 6, where 1 is just the main thoracic curve that is major, and it is structural. All the others are not structural. They are minor curves, but they are not structural. And 2 is where you have kind of like a double thoracic. You have 2 thoracic curves, but the main thoracic curve is, of course, the major one. And the other one is minor, the proximal thoracic, but it is structural. 3 is kind of like a double major where you have a main thoracic curve, and you also have a thoracolumbar or lumbar curve. So you have a thoracic curve and a lumbar curve. And then 4 is what you call a triple major. You have all the 3 regions represented in that one in terms of structural curves. 5 is easy to remember because it's only the lumbar curve or the thoracolumbar curve that is present. All the other minor curves are not structural. And 6, you only have the main thoracic curve, and also you have the thoracolumbar curve. But the thoracolumbar and lumbar curve are the ones that are major. So that is just the way that we classify that. There are some modifiers that are there, the labor modifiers, and also the modifiers that just the general kyphosis thoracic spine. And these are things that one could just look at and try to classify this, but I won't go into that because of time. There is one time that I was kind of handling a main thoracic curve, but I missed a curve that was at the proximal edge that was structural. And at the end of it, I was able to stretch the main thoracic curve, but then the shoulder balance kind of just went reverse. The patient was happy, the mother was happy, I was unhappy. So because I could see what I had done, I had just reversed the way that the child was looking post-op compared to how she was looking pre-op. But one test to remember some of those things. This is a child that I also did who was about 16, 17 years of age, but had a main thoracic curve, but also had a lumbar curve. This lumbar curve seemed to bend out to less than 25 degrees, but there was a lot of significant rotation that I could see in the lumbar vertebra. But because the degrees were less than 25 degrees, I considered this at that time to be a minor curve that was not structural. So I just did kind of selective fusion of the thoracolumbar, of the main thoracic curve. Then at some point I was called by the parents and they said, we are concerned about the crease, there is that crease that was there. And I had to scratch my head to just wonder what to do about it. And just looking at it, the spine was kind of taking off quite obliquely from the pelvis, but then also the curve in the lumbar spine looked like it was quite significant. I had tried to do selective fusion just because I wanted to save a lot of the lumbar segments, and that's why I had kind of left that out, just thinking that as the child continued to grow and heal, this curve will become less severe. But the child has been having that persistent crease. I've been monitoring just to see whether the curve is going to increase, to know whether I need to extend that curve. Usually Lenke proposes that all the structural curves need to be included in the fusion. And maybe I should have extended that a little bit more. Now, when do you need to do MRIs? Of course, there is a long list of things. One of them that wants me is just a left convex thoracic curve. And of course, if the curve is either short and very severe, or there is a rapid progression of the curve, whether there is excess kyphosis at the thoracic level. Of course, if you have any neurologic abnormalities, you also think about that. And of course, pain. If you have significant pain, there might be something happening in the spine that needs to be investigated. This is a child that had mainly the thoracolumbar curve, but also had also a main thoracic curve. And initially, I had thought that it was an idiopathic adolescent scoliosis, but then we realized that the right leg was weak. So we did an MRI. This surgical scar was a neurosurgical scar. There is a neurosurgeon who did some operation there. But that's after we referred the child to the neurosurgeon. But when we looked at the MRIs, we found that there was a kind of a split in the spinal cord. And then recently, when we were doing the surgery, the bony features around that level are also a little bit different from what we normally see. But we had to have the child seen by the neurosurgeon and handled by the neurosurgeon, and then later we had to do the spine surgery. So split cord is one of the things that you might see, or the osteomatoma area. Yeah, This child was 17 years of age, but had a left thoracic curve. But also there was kind of significant scoliosis, not kyphosis. So we just did an MRI. And what we found there was in the cervical spine, there was a very huge syrinx that had to be attended to by the neurosurgeon. So again, an MRI was very important for us to do that. So in general, treatment starts when the curve goes beyond 25 degrees. If it's below 25 degrees, usually people just observe. But if it is above 25 and it seems like it is progressing by more than 7 degrees, then one might start thinking about doing some form of treatment. Initially, up to about 40, 45 degrees, people would do bracing or conservative treatment. And then when you go beyond there, 45 degrees, 50 degrees, just because of the curve being more severe, then to undertake. The goal of surgery, the curve progression, but people have also, with improved instrumentation, been able to achieve quite a lot of correction and improve the cosmesis and balance and shoulder balance and all that. Those are just some of the patients that we have done. For the rib hump, especially if one is able to do direct vertebral rotation at the thoracic level, that helps to control the rib hump that usually is caused because the vertebrae are very rotated, especially at the apex of the curve. But also there are people who actually go directly on the chest wall and resect some of the ribs and do the thoracolplasty just to be able to decrease that hump and improve the appearance of the patient. These are some of the patients that we did. I just took a quick look at them just as I was preparing this presentation. I think we achieved just about 50% correction of the main curve that we undertake to do. The average number of segments that we have generally included in the fusion is about 12. And implant density, which has also been another topic of discussion, for us has been quite low for many reasons. But a lot of people, especially in the Western world, go around 1.5, 1.6, 1.7 implant density or anchor density. Now, the anchor density is when you consider the number of anchors divided by the number of levels of instrumentation. Now, people have thought that high anchor density, especially when you're using pedicle screws throughout, you're able to improve a lot on the coronal correction of the curve. Also, to some extent, the sagittal correction is still debatable whether increased correction results in a greater patient satisfaction. But that is something that would be expected. But I have also seen a lot of patients being very happy even when they have not been corrected completely. The ideal anchor density is not yet determined. Yeah. So for us, of course, we grapple between the balance between increasing the number of anchors and the cost of implants, difficulties in inserting them. And also associated with the difficulties, there is the safety, because sometimes you can go through the spinal canal and or even affect a nerve root. And of course, the increased time and bleeding that is associated with the increased surgery time. So I think over time, we will continue to increase the density of anchors, but all these factors come into play. I think that's all that I have. Thanks. Hello, over to you.
Hello, over to you.
Okay, I think I can't hear you, Irene. Okay, I think I will just go to the question that I can see here. Let's see, radiographic assessment. When do you consider studying lateral view as part of initial screening of the thoracic curve? In the case of more severe cases of scoliosis, that curve that do not straighten to less than 50 to 60 degrees, what do you do? Do you do anterior and posterior or just do posterior? If so, what is your success? Do you use neuromonitor? If not, how do you avoid excessive traction? I use neuromonitoring for most of the cases. Initially, we didn't have it available, but recently we have been using it more and more. For bedding fumes, the ones that are considered standard are the ones that are taken supine, just to be able to correct the curve. Now, for curves that are very severe, as you saw there, I'm able to correct maybe on average about half the curve, but what you're looking at is to make sure that the cosmetic appearance of the patient is better in terms of trunk balance, both sagittal and coronal, but also the shoulder levels, whether they are balanced or not. So once those ones are achieved, quite a lot of times you don't have to correct completely or the curves that are presenting themselves. For the minor curves, because people now kind of do more selective fusion, once you correct the main curve and the minor non-structural curves usually are thought that they will improve over time. So you don't have to include them in the fusion. But for the minor structural curves, quite a lot of times you need to include them in the fusion. Are physiotherapy or corsets useful at all? Yeah, physiotherapy has been considered to be one of the conservative treatments of adolescent idiopathic scoliosis, especially the flexibility and core strengthening exercises. Corsets, I would say the TLSOs that are specifically fashioned for scoliosis, where you actually do an X-ray to just make sure that you're able to correct the curve through the forces that you apply when you're molding, to just make sure that you're just not keeping it there where you found it, but you achieve some correction through the corset. I think that is an important thing to just know that it is going to be effective. And of course, those are curves that are less than 40 degrees. Above 40 degrees, of course, physiotherapy is always useful to the patient, but about its success in achieving correction or maintaining correction or preventing progression of the curve is not something that has been thought to be very useful. Zakaria, okay. Do you have spine center in this country? And in such cases, who are the team involved? Well, I think in terms of spine, Kenya has developed a lot because we have a spine group that meets quite regularly, led by Dr. Obachi, and it involves all the surgeons that are doing spine within the country, both the orthopedic and spine surgery. And that type of collaboration is very, very important because of just that colleague education and just progress together. But also the number of centers within the country that are doing spine surgery have continued to increase over time. And that, of course, is a very positive thing. So the spine industry, the spine surgery, it's improved quite a lot and is continuing to develop. How much reduction of movement? Goku, Dr. Goku, you're talking.
No, sorry.
Okay, thanks. Okay, how much reduction of movement do patients have after surgery on 10 to 12 segments? Well, people try to save as much of the lumbar spine as possible because it's the most flexible segment of the spine, besides of course, the cervical spine. But the thoracic spine usually is not that, there's not a lot of movement that occurs at the thoracic spine. And the thoracic spine is the most commonly affected by scoliosis. So just considering that you have some segments in the lumbar spine, and also you have hips that are functioning normally, I think the flexibility for the patient is quite reasonable just because of that. But even when you have said that, there is a lot of investigation that is going on about where the implants ends, whether you are going to have degenerative changes because of a very stiff instrumented segment, and then there are also other segments that are not instrumented. Whether instrumentation of spine causes the parts that are just adjacent to the instrumented sides parts to degenerate quicker, especially as one continues to age. So flexibility, of course, is a factor, and I'm sure they lose some, but as long as you save some lumbar segments, and also if you have normal hip motion, I think you are able to function fairly normally. How often do you encounter crankshaft phenomena during follow-up post-reduction? Well, we haven't followed up the patients, of course, for long, but it's generally agreed that you shouldn't do major extensive spine surgery before 8 years of age, again, just because of the crankshaft phenomenon. So for this type of operations, you are waiting at least up to 10 years of age to be able to do fusion on large segments of the spine to avoid the crankshaft phenomenon. How much reduction of a curve do you aim for in terms of percentage? I think most of people in the developed world usually, when I looked at the papers, they were ranging between 60% and 70%. There are very few that were actually recording 100%, actually none. But I think at 50 to 60 is still not bad. But the developed world, where they are literally instrumenting every level of the spine, and they are using pedicle screws, so they have more power to do correction. They are actually looking at about 60-something% of curve correction. Do you do anterior stabilization as well? Well, for the scoliosis, especially adolescent idiopathic scoliosis, most of people usually do the posterior surgery only because a lot of segments are involved. I know there are some centers that still try to do anterior surgery, but most people usually will just do posterior surgery alone without anterior surgery. Again, with the use of pedicle screws, you're thinking that you're instrumenting the 3 columns of the spine because the screws go all the way to the vertebral bodies. So they have just more strength to be able to achieve correction without actually going physically to the anterior aspect of the spine. How close are you in current time to use growing rods? Growing rods are used, and we have actually been using some at Cure for early onset scoliosis. The reason, again, is because we don't want to fuse large segments of the spine in a growing spine to avoid crankshaft phenomenon, but also to make sure that the spine grows to a length that is able to allow lung development for the child. So as a result of that, we use growing rods. They have a lot of complications, especially just in terms of failure. There are skin issues, but there are also failure, especially at the anchors between the implant and the spine. And occasionally some of them break. And that is some problem that has been found worldwide to be an issue. But also the other thing was just because you have to keep getting the patient back to theater to be able to push the load a little bit longer. Maybe about every 6 to 8 months, you have to take the patient back and distract the rod there are some centers where they use a magnetic mechanism to distract or to achieve distraction without having to open up the patient every time that they need some lengthening. So those are more expensive, not easily available in Africa, but also they have also been having some issues with the failure of that distraction mechanism for some of the rods. So even then, they are new, and we will continue learning from them. What is the upper age limit for the surgeries you presented? Well, for us, we will do surgeries maybe up to about 20 years of age. But we know that there are people that do corrective surgeries even on adults who have scoliosis, either because they had it as an adolescent or they had it because of degenerative conditions of the spine. So for posterior spine surgery for scoliosis, whether it is idiopathic or degenerative, one can do it as long as the bone quality is good. When do you start physio? Well, we start treating patients with scoliosis when they hit about 25 degrees of Cobb ergo. And usually at that time, you can start conservative treatment. Sorry, up to the time that you deem necessary to stop because the curve is not responding to physiotherapy. Yeah, but as long, once they go towards 50 degrees, one should start considering surgery for that. Yeah, thank you. I think I have gone through all the questions that I can see here. I think I'll get back to give the floor back to the presenter.